Chapter 40 talks about some various respiratory disorders. Just a few things as we're starting to talk about some of these different respiratory disorders. You want to think about what would be some key things that you might be looking for as you were doing a physical assessment on a child who had been admitted with some type of respiratory illness. Certainly we're looking at the cough. Is it productive, non-productive? What about the rate, depths of their respirations? Are they tachypnic perhaps? Retractions, are they having any substernal intercostal retractions? The other thing that we might think about, especially with an infant, would be, are they having any nasal flaring? The restlessness, which may be a sign of hypoxia, and then certainly another sign of hypoxia or problems with the respiratory system would be signs of cyanosis in the child. This slide, this picture is from your textbook. You can kind of just review some of those respiratory symptoms that may be associated with some of the respiratory illnesses that we're going to talk about. The list on this slide are those things that I want to cover with this PowerPoint and really kind of want to focus on from this chapter. I would encourage you also with these particular respiratory disorders to look on the ATI DVD. You'll have some more information being shared with you through that DVD, as well as in your ATI book, and then certainly in the Pilitary textbook as well. Starting with some upper respiratory tract disorders, pharyngitis. Can be viral or bacterial in nature, and you have a review of symptoms and treatments for either viral or streptococcal pharyngitis on pages 1246 to 1247 in your textbook. Certainly one thing to think in mind with a viral infection, antibiotics will be of little value in treating that, so we really have to go at symptomatic management. You know, what might some of those symptoms be? Well, probably a low-grade fever, maybe some malaise, a sore throat. So we think of analgesics, gargling with salt water, those types of things as that symptomatic care. When we're getting and talking about the streptococcal pharyngitis, we have to remember this is caused by a bacteria. So management with antibiotics is important. It's important to stress with the parents that the child take the full course of antibiotics. The one thing to also think about when a child has a streptococcal infection is there is that slight risk of the child developing either rheumatic fever or glomerular nephritis, both of which are caused by that group A beta hemolytic strep. Again, it's a very small percentage of children who would develop that, but that is a risk when we're talking about a streptococcal infection. Tonsillitis, a few things to mention about tonsillitis. Again, kind of when we have an inflammation of the tonsils. Oftentimes children who have those repeated cases of tonsillitis end up having a tonsillectomy. And generally we think about tonsillectomies as being a fairly, if I could use the word benign or even somewhat routine childhood surgery. I'm sure many of you may have had your tonsils out as a child. And that's true for most cases. Tonsillectomies are usually performed on an outpatient basis, so it doesn't even require an overnight stay typically. But there is a threat of hemorrhage with tonsillectomy, so we still, even though it seems like we're only going to see the child in the hospital for a short amount of time and it's going to be an outpatient surgery, we still have to think about pre- and post-op care and that there is that risk of hemorrhage. Following a tonsillectomy, there are 2 times when a child is most at risk for hemorrhage. Within the first 24 hours after the surgery, that's as clots are starting to form on that surgical site. And then about 5 to 7 days post-op as those clots are starting to lyse or dissolve. Kind of thinking pre- and post-op care, Pre-op care, obviously a couple things to keep in mind. First, the child has to be healthy. They can't have an active case of strep or tonsillitis going into surgery for a tonsillectomy. We're setting up a scenario increasing the likelihood of sepsis developing. You know, why is the child having the tonsillectomy in the first place? Probably because they've had repeated cases of tonsillitis or strep throat. Oftentimes they may put the child on a low dose of antibiotics leading up to the surgery so that we can keep them healthy, get them into surgery, and get those tonsils out. Another thing to think about pre-op is checking for loose teeth. We certainly don't want any teeth to get dislodged during the surgery and end up somewhere they're not supposed to, other than under the child's pillow for the tooth fairy. The other thing to think about preoperatively is that risk for bleeding. It would be appropriate to draw a PT and a PTT on a child who is going to be having a tonsillectomy, so we make sure that bleeding times, clotting times are all within normal limits. I will tell you that routinely this is not done. For a typical child coming in for a tonsillectomy, they probably would not have that blood work done. But again, knowing that there is that risk of hemorrhage with the surgery, some of the questions to ask on that admission history or that pre-surgical history: does the child have any history of prolonged or excessive bleeding? Is there any history of excessive bleeding or bleeding disorders in the immediate family member? So again, so that we are addressing that issue. Post-operatively, again, we've talked about the risk for hemorrhage. And I would refer you to the care plan for a child who's had a tonsillectomy that starts on page 1248 and continues on through page 1250. It outlines very well some of the nursing responsibilities during that post-op time. Just a few things to say again about that hemorrhage. You know, oftentimes I think when we hear the word hemorrhage, we just think about bleeding and, you know, excessive bleeding and blood is just spewing out of every orifice in the child's body. When we think about that post-op tonsillectomy patient who is having some excessive bleeding, a lot of that bleeding is disguised. You know, think about where that surgical site is. It's in the back of the throat. So as the child starts bleeding from that surgical site, what's their first response going to be? They may be doing a lot of frequent swallowing, or they're kind of clearing their throat. We might see them getting kind of a little bit restless. So we have to be looking for some of those early signs of hemorrhage. Again, that it may not be that we just see all this, you know, that the child just immediately starts vomiting large amounts of blood. A few things to try to minimize the risk of hemorrhage: keeping the child's activity level very low. Usually they're told to stay home from school and not participate in any sports activities for the first week post-operatively. We discourage the use of straws with these children because, again, the sucking action on the straws can put some increased pressure on that surgical site and may initiate some bleeding. We always will tell the parents, don't give the child any red liquids to drink, like the red popsicle. Popsicles are good in that post-op period, but we don't want to give them anything red because if they do have an emesis, we may be left wondering, is the child having some bleeding, or is this just the red popsicle that they drank? Pain is certainly an issue post-operatively that we're dealing with as well. Initially, a child may have some difficulty swallowing oral pain meds. So if we have IV access, we may need to give a couple pain medication doses IV before we switch to that oral form and send them home. Ice packs, ice collars certainly work well. That also, an ice collar kind of serves a dual purpose. It helps with some vasoconstriction to minimize bleeding, and then will also help with the pain management as well. When we're thinking about diet, again, I mentioned avoiding the red fluids, but we want to think about, soft foods, avoiding foods that are real spicy or very warm or hot in temperature. And again, I would just refer you to the plan of care outlined in the Pilitary textbook. Epistaxis, there's just a brief paragraph or two in your textbook on page 1250 on epistaxis, so you can read through that. Obviously, we're talking about a nosebleed. Probably all of us have had a nosebleed at one time or another, whether that was caused by a trauma, getting hit in the nose or falling, or perhaps in a very dry environment. Sometimes that may be a cause of a nosebleed as well. For children, it can be very frightening. So again, the book mentions trying to keep the child quiet, and if they're crying excessively, that may just, make it a little bit harder to get that bleeding to stop. So if we can try to calm them down. As you can see by the picture there on page 1250, what are we doing? Encouraging the child to lean forward a little bit, not hold their head back, which is sometimes their first instinct to do that, but lean their head forward, pressure on each side of the nose. And again, as it mentions in your textbook, a nosebleed, infrequently is certainly probably no cause for concern. A child who is having repeated nosebleeds or very frequent, we may need to do some further evaluation to rule out any type of bleeding disorder or other potential medical cause for those frequent nosebleeds. Two respiratory disorders that are similar but yet different are croup, or the technical term for that is laryngeotracheobronchitis, or sometimes abbreviated LTB. Now you can see why we prefer to just call it croup, and epiglottitis. Both of these are respiratory disorders that we find oftentimes in children. This slide gives you a nice comparison and then some contrasts between the two. Again, just to kind of point out a few things related to these two disorders. Typically, croup is a viral infection. So when we're thinking about a viral infection, again, remember, our treatment is going to be aimed at the symptoms. Well, what are some of the symptoms that we typically hear? Probably one of the classic ones we think about with croup is that barking cough, or that seal-like cough, like the seals at the zoo. The child may sound like that. Typical scenario with croup, what happens? Parents wake up, it's 3 in the morning, hear their child just making these awful sounds, that real barky cough. They may have some inspiratory stridor, where it's kind of that high-pitched crowing sound. Obviously very frightening for the parents, so they pack the child up, off to the emergency room they go, get into the emergency room, and suddenly look at the child and think, he looks like he's breathing pretty well. We don't hear a lot of that cough. What's probably the scenario that's happened here? Again, you can see, when does this typically occur? Late fall, winter. It's 2 or 3 in the morning. The parents have taken the child outside into that cool, moist environment. The air is a little bit moister at night. The child has breathed that in, and that has actually helped to ease some of the symptoms. It's rare that you would see a child admitted to the hospital for croup, but depending on the circumstances, they may be in the hospital. Again, what are some of our symptomatic management? Sometimes we hear about, we take them in the bathroom, with a hot, steamy shower, and I just mentioned to you the cool, moist air. It really doesn't matter if it's the steamy bathroom or the cool night air. The thing that is most important is that humidification and the moisture in the air. Vaporizers now that you buy are typically those cool mist vaporizers, and they've really switched to those cool mist ones just because of safety issue, decreasing the likelihood a child is going to get injured or burned. Sometimes steroids are used as well. Sometimes some bronchodilators by aerosol may be used as well. Now with epiglottitis is typically caused by a bacteria. Excuse me. The thing to think about with epiglottitis is, when we're thinking about it in comparison to croup, epiglottitis is a much more emergent situation. This is a child who needs to be seen and treated immediately because the risk of complete closure of that airway is very high. Again, you can see the difference just even looking at the fever. With epiglottitis, the child has a very high fever, whereas with croup, it's very low. Again, similar when we've got bacterial infections, the temperature usually will be significantly higher versus a viral infection where we typically have that low-grade fever. With epiglottitis, I like to think about 4 Ds in remembering the symptoms that you'll see. One is drooling. The child, because that airway is becoming so inflamed and obstructed, is having difficulty managing their oral secretions and can't swallow, so we may see a lot of drooling. Dysphagia, or the difficulty swallowing. Dysphonia. This is a child who's probably going to be having some trouble even speaking. And then dyspnea would be the 4th D, again, where they are going to have some marked difficulty with their respiratory status. Again, epiglottitis needs to be treated immediately. If you are working in the emergency room and you hear that they are bringing a child in with suspected epiglottitis, what's one of the things you should do? Make sure that you have pediatric intubation equipment readily available, as well as someone readily available who is able to intubate a pediatric client, because it is likely that they may need some mechanical ventilation until the symptoms can be controlled and managed. One thing that's also listed on your slide and in your textbook as well is under the appearance area, where it says, do not attempt to view the enlarged epiglottis, or immediate airway obstruction can occur. A lot of times when I'm looking through review books, this is one of the things that they ask about. When you've got a suspected case of epiglottitis, we don't want to do anything that's going to cause the child to perhaps start gagging or coughing. We don't want this child getting very upset. We want to keep them very calm, because if they do start gagging or coughing or crying very vigorously, that may not be enough to just cause complete obstruction. Say there's a suspected case of epiglottitis. A resident comes in and says, oh, go ahead, can you get a throat culture on this child? I think it might be strep throat. What would your response be? No, I'm sorry, I can't do that until we can rule out the epiglottitis. Because, again, if you've ever had a throat culture, you know what happens when they swab your throat to get that culture. It initiates that gag reflex, so we would not want to do that. So again, I thought that was a nice slide. Again, you have that in your textbook as well. On page 1253 and continuing on through page 1255, you also have a care plan for a child with croup. So I would encourage you to review that as well. A few things I want to talk about related to RSV, or respiratory syncytial virus. RSV is a really common cause of upper and lower respiratory infections in young children. Anyone of any age can get RSV, but probably when it kind of packs its biggest punch is when it's affecting infants and young children, probably children under 2 years of age. And then even further than that, if we think about high-risk groups, it would be children in that age group, 2 and under, who also have some type of underlying medical condition. It is transmitted through contact, it's not airborne, and it is very communicable. The virus can live on surfaces for several hours, again, so making it very communicable. Just to think about, if you have a patient in the hospital who has RSV, they would be in contact isolation, so gowning and gloving would be appropriate. A mask would not really be necessary because it's not something that you're going to breathe in. Typically, we'll see RSV occurring in the winter months. Usually, the season would be considered probably from November to March when we see most cases, although we could expand that depending on the area of the country or the type of weather that we're having. It's not unheard of to have RSV start in even late September, October, or still be seeing RSV cases in April or even May. But again, typically that November to March season. The incubation period with RSV is 2 to 8 days, and again with incubation period meaning from the time the child is exposed until the time those signs and symptoms develop. With RSV, some of the symptoms that we think about, a lot of nasal congestion, coryza, a cough, sore throat, fever. Again, usually it's very copious amounts of respiratory secretion. Typically, to make a diagnosis of RSV, they look at the symptoms that the child is experiencing, as well as do an NP wash, or a nasal pharyngeal wash. With that NP wash, basically what you're doing is putting a few drops of saline in each nostril and taking one of those blue bulb syringes, which, you know, the kids start crying when they see those blue bulb syringes before you've even touched them. But you're going to use that blue bulb syringe, get as much sucked out of their nose as you can as far as secretions go, put that in a specimen container, and that's sent down to the lab. Again, remember, this is a virus, so symptomatic management. So if we're thinking about the symptoms with the respiratory issues, certainly humidified air would be appropriate. Bronchodilators, aerosols certainly would be appropriate. Keeping the child hydrated is also would be important as well. I've listed 2 medications here that when we're thinking about RSV. One is ribavirin. That's an antiviral medication. Again, so it won't be a cure for the RSV, but it may help to minimize the symptoms. A couple things about ribavirin. It is not something that you will see being prescribed for every child who gets RSV. Ribavirin is usually only given in those instances where a child's respiratory status is declining, they're not responding to symptomatic management. Ribavirin is given by an aerosol. It has to run, I think it's like 18 out of 24 hours a day for several days. Women who are pregnant cannot care for a child who is receiving ribavirin because of the teratogenic effects of that medication. Again, a woman who is pregnant is okay caring for a child with RSV, but if that child with RSV is receiving ribavirin, then they should not be assigned to care for that child. A medication that's been around for a couple years now, but that really has started changing the incidence of RSV and its effects on young children, is a medication called Synagis. And I guess if I had to kind of briefly explain Synagis, I would say it's kind of like the flu shot for RSV. At-risk children, so again, those children who are 2 and under, who have some other underlying health condition, can receive monthly Synagis injections throughout the RSV season, and it really is kind of a vaccine, so to speak, or it provides some of that passive immunity against the RSV virus. These injections are very expensive. Per injection, you're probably looking at least $1,000, if not a little bit more. A child gets one of these injections each month during RSV season. So you figure a typical RSV season running from November to March, that's 5 injections at $1,000+ a piece. Obviously, insurance companies are only going to pay for this or cover this if you have a child falling in that high-risk category. Information on some other lower respiratory tract disorders, asthma. There's a case study that is included on Blackboard on Tommy Hill, as well as you have some good information on asthma on pages 1259 to 1264, excuse me, in your textbook. And I did just also want to make special note of the 2 medications that are profiled in your Focus on Pharmacology boxes in Chapter 40, on albuterol and on Intol as well. So again, I think the case study really does a nice job of outlining some of the issues related to asthma. And I think that between that and looking at those pages in your textbook, you'll have a good understanding of that. This is another good reference comparing, looking at bronchiolitis, again, which is typically caused by RSV, looking at pneumonia, and then looking at asthma and seeing some of the differences and similarities between those between those 3 illnesses. The other respiratory disorder that I'd like you to review from this chapter is cystic fibrosis. Those of you that are having your clinical rotations at Toledo Children's Hospital are very likely to care for children with cystic fibrosis during this course, because the Toledo Children's Hospital does tend to be, or is, I should say, the regional center for pediatric pulmonology, and again, specifically cystic fibrosis. Certainly it is a respiratory disorder, but there are other body systems involved in addition to the lungs. The pancreas and the sweat glands are also involved with this particular disease. How do you get cystic fibrosis? Well, it's an autosomal recessive disorder. So if we have a child who is diagnosed with cystic fibrosis, and mom says, oh, this must come from dad's side of the family, and dad says, oh, not my side, it must come from mom's side of the family. In truth, a child who has cystic fibrosis inherited that gene from both parents. So you can go back to some of your earlier classes, back some of your science classes when you did all those inheritance tables, and look at with autosomal recessive, if you have a couple, both of which are carriers of the cystic fibrosis gene, what's the likelihood that their offspring will have the disorder? And that would be, there is a 1 in 4 or 25% chance. I know just looking or listening to that, saying, okay, if both parents are carriers, there's a 1 in 4 chance that their child may have the disease, and you're kind of thinking, okay, I need to see that. Look in your textbook on page 162, and there's a table there that really outlines how you can figure that out with autosomal recessive, with H indicating there's a healthy gene, the little d would be the disease gene, and you can look at and kind of read through how does that autosomal recessive inheritance work. So again, looking at pages 162 and 163 in your textbook. Thinking about cystic fibrosis with our assessment, The sweat chloride test with children who have cystic fibrosis, there is an excessive amount of sodium and chloride excreted in their sweat, so that is one of the tests that they will use. Also, just to mention, with cystic fibrosis, I believe it began in October of 2006. You've probably heard of the PKU testing, or the newborn screening that takes place when a baby is born and before they're discharged home. Cystic fibrosis was added to the list of all the different diseases that they test for now in the state of Ohio with that newborn screening. Again, I believe it was October of 2006 that first began. Looking at duodenal analysis, stool analysis, with cystic fibrosis, on the earlier slide it mentioned the pancreatic involvement. Children with cystic fibrosis lack the pancreatic enzymes that help break down food that they ingest. Because of that lack of pancreatic enzymes, they tend to have steatorrhea, or their stools are very bulky, foul-smelling, again, contain a lot of fat. So that would be another thing that they would be doing as well in looking at the assessment and making that diagnosis. And then certainly the pulmonary testing as well. Therapeutic management. At this point, there is no cure for cystic fibrosis. The gene has been identified. Certainly we can look to the future and think with gene therapy and those types of things, but at this point there is not a cure for this illness. So our management is managing those symptoms with the involvement of the pancreas and the lungs. Starting on page 1271 in your textbook and continuing on for a few pages, again, you have a nice care plan that looks at some key nursing diagnoses for this disorder, as well as what are some of the treatments. Just thinking about their problems with nutrition, again, because they can't digest that fat. I said earlier that they lack those pancreatic enzymes, so what do? We give them those pancreatic enzymes in a medication form. They take those pancreatic enzymes with each meal and each snack. These are kids who can eat lots and lots of food and never gain any weight. So as it says in your textbook, they usually put them on a high-calorie, high-protein, moderate-fat diet. Again, when we think about those fat-soluble vitamins, A, D, E, and K, they may be deficient in those fat-soluble vitamins, and we may need to supplement those in a water-soluble form. But again, CF kids are usually the ones that are definitely going to be a lot smaller in stature when we go back to thinking about those growth charts. A child with CF wouldn't be unusual to see their weight falling in that 10th percentile, that 5th percentile, perhaps even below. Respiratory symptoms certainly are important to manage as well. The aerosol therapies, they need treatments several times a day, oftentimes around the clock. And again, when you start thinking about doing those aerosol treatments, that chest physiotherapy, that can, a treatment could take a half hour, 45 minutes. We're doing that 4 times a day on a daily basis. You don't get to slack off on the weekends. You can see what a toll this can take on the child and the family as far as interfering just with daily activities.